Well, good afternoon, everyone. I hope you enjoyed your lunch, and we're going to be fighting the after lunch sleepiness, but I'm sure that our speakers are going to be dynamic and exciting, and we're not going to have to worry about that at all. I'm Doreen Markle. I'm the director of the Brehm Center here at the University of Michigan Medical School, and the Brehm Center works on diabetes-related issues and decided that learning health system and diabetes went hand in hand, and we wanted to take on doing some things in that space. And that's my connection to the department, and I have a faculty appointment there. Our last panel for the symposium is going to focus on the empirical studies in the ELSI-LHS space. As we already heard from Dr. Sugarman earlier in the previous panel, there are serious ethical questions that can arise in such trial design, particularly at the intersection of clinical practice with current patients and improving the practice for future ones. And being able to do this, not just at the patient level, but at a level of scale. Our speakers on this panel are going to take a slightly different focus and discuss how biospecimens and health data end up in our systems for ongoing secondary use and the challenges that that presents. Our first speaker this afternoon is Dr. David Magnus. He is the Thomas A. Raffin Professor of Medicine and Biomedical Ethics and the Professor of Pediatrics and Medicine at Stanford. He is the former president of the Association of Bioethics Program Directors and is the editor-in-chief of the American Journal of Bioethics. He was a member of the Secretary of Agriculture's Advisory Committee on Biotechnology in the 21st Century and currently serves on the California Human Stem Cell Research Advisory Committee. Dr. Magnus has published articles on a wide range of topics in bioethics, including research ethics, genetics, stem cell research, organ transplantation, end-of-life issues, and patient communication. Welcome, Dr. Magnus. I'm going to introduce our speakers, and then we're going to do the same sort of format as last time, 15 minutes presentation. We're going to hear a little bit about the writing sprints from yesterday, and then we'll do our panel at the very end. Our second speaker this afternoon is Dr. Kirsten Auster. Dr. Auster is the Gladys Lewis Fox Professor of English at Rice University in Houston, Texas, where she is a media scholar, health researcher, and technology analyst. She is the founder and director of the Medical Humanities Program and the Medical Futures Lab. Her research on trust and privacy in digital health ecosystems has been featured in Slate, The Washington Post, Big Data and Society, and Catalyst. She is currently writing a book called Qualified Health: Learning from Patient Stories in the Age of Big Data. Thank you for joining us, Dr. Auster. After Dr. Auster, we will have several representatives from our writing sprint from yesterday come forward, and I'm just going to briefly introduce them now. I've got some notes that were just given to me, so hopefully I'll be able to read everything clearly. So yesterday afternoon, there were writing sprints going on, and there were 4 different groups, and the leaders of each of those 4 groups are going to do a quick reporting out. So Zach Landis-Lewis, who's a faculty member from the Department of Learning Health Sciences, Meena Raj, who's a doctoral candidate in the School of Public Health in Health Services and Organization Program, Dr. Ray DeVries, who's a sociologist and faculty member in the Department of Learning Health Sciences and the Associate Director of the Center for Bioethics and Social Science and Medicine, Gracie Trinidad, who is a doctoral candidate also in the Department of Learning Health Sciences in the PhD program in Health Infrastructures and Learning Systems. And Jody will come up at some point and help with that as well. So I'm not sure what Jody's going to do. Jody's going to do something. Finally, I would like to introduce Dr. Reshma Jagsi, who is our discussant for the panel this afternoon. Dr. Jagsi, see, I told you I would do that, is the professor and deputy chair of the residency program in the Department of Radiation Oncology and director of the Center for Bioethics and Social Sciences and Medicine at the University of Michigan. And that center is also co-sponsoring the symposium. She is an active clinical trialist and a health services researcher. Her medical research focuses on improving the quality of care received by breast cancer patients, both at advancing the ways in which breast cancer is treated with radiation and by advancing an understanding of the patient decision-making process, cost, and access to appropriate care. Her social science research examines women's representation in the medical profession and issues of bioethics arising from cancer care, including an NIH R01 funded deliberative democracy study of cancer patients' perceptions of the ethical implementation of learning health systems in oncology. Welcome to you as well. Dr. Magnus, if you'd like to take it away.
Thank you very much. So thanks, it's a great pleasure to be here. I want to thank Kate and Jody and Ray and everybody here for inviting me. It's been really interesting and I feel like I've actually learned a lot. I think I almost am starting to learn and understand what the learning healthcare system might be. So thank you for that. Let's see if this works. No, so.
We get the pointer to work again, see? Oh my goodness gracious.
So let's see.
Here, wait, there's a third.
Oh, I see. There we go.
There you go.
There we go. So I have no financial conflicts of interest. I have a potential, I guess, conflict of commitment. I'm the vice chair of the NIH Precision Medicine Initiative All of Us research program, IRB. I didn't think of this as an issue, but I also am on the working in ethics regulatory group that Jeremy co-chairs that he described earlier. And since he said that's relevant potential conflict of commitment, I should probably say the same. Okay, so, oh, and also I like learning, so. Okay, so when you think about the learning healthcare system, and when we think about how we were talking about it back when Nancy and Ruth and everybody was sort of working on this, and around the same time that we were working on support and we were doing a whole bunch of research, we called it ROMP, or Research on Medical Practices. In the research that we were all doing, we really were thinking about pragmatic trials, and we were thinking about ways in which we were essentially doing different kinds of comparative effectiveness research. But if you really think about it, there's lots of different intersections with learning health system and other kinds of activities, including precision health. And if you really think about it in one way, we're really talking about what we can learn from all the data and information that's out there, and then eventually have these feedback loops that are going to have to go around. But there is lots of different kinds of data, and that data includes not just electronic health record data, but potentially biospecimens and the genomic information we can get from them. So the idea of a genomics-enabled learning healthcare system has come out in the last couple of years and been something that people have talked about. Let's see. There we go. I think this might have come out of this meeting 2 years ago, talking about the way in which, in an era of genomic medicine and genomics and learning healthcare system work together, could potentially help to actually improve rather than make equity issues get worse. This is going to be relevant for the comments that I'm going to make, because I really want to talk about the two primary sources of data that sort of exist in health systems. Obviously, there are other sources of data that can be collected. We can do surveys, we can do other things, but two of the primary sources of data that people think about, which are electronic health records and biospecimens. And obviously, the biospecimens include leftover tissues and samples from clinical care. They can also include things that are actually derived from research. And then, of course, there's genomic information, as well as other information that can be, and other assays that can be done on those biospecimens. Now, the first point I want to make is to just recall that under the common rule, before the rounds of revisions, the regulatory system for at least secondary uses of de-identified data, it didn't really matter whether those were biospecimens or data derived from biospecimens or other parts of the electronic health record. They were treated the same way. As long as the data was de-identified, it was considered not human subjects research, as long as there was no way of re-identifying. But and it's appropriate that it's close to Halloween, because the NPRM, the Notice of Proposed Rulemaking Change, I think scared all of us about what the changes to the regulations might look like. And in the Notice of Proposed Rulemaking Change that was made, they actually decided that these things would be cleaved completely apart, whereas they had previously been together, that instead there would be biospecimens and exceptionalism, that for secondary uses of electronic health record data, it would continue to exist as it had been before, that as long as you couldn't re-identify subjects or otherwise conduct an analysis that would lead to creating individually identifiable private information, that research was outside of the regulatory system, as not counting as human subjects research. But all biospecimen research, whether it's identifiable or not, would automatically be made human subjects research, and therefore they created this concept of broad consent with a number of required research elements in order to be able to use biospecimens in research. Now, at the time this came out, a colleague, a friend of mine at Penn, Steve Joffe, wrote a piece criticizing many aspects of the NPRM, but one of the things we criticized was what we called biospecimen exceptionalism, and we argued that there's no real argument that they provided to show that there's greater autonomy rights over one or the other, that the confidentiality risks might be just as great or greater in electronic health record data as in biospecimen research. And so we questioned the validity of this, and we especially were worried about what the impact of this exceptionalism might be on people who get their health care at under-resourced institutions, and that this might actually create further inequalities. And we didn't say that that was the end of it, but we said we need to have a lot more information, a lot more data before we're going to, about what people think about these issues, before we can really make these decisions to really instantiate a fundamental distinction and cleavage in the regulations. Oops, let's see. I'm not used to, I'm a Mac user, so I'm not used to this whole right click thing. Oh, there we go. Okay, oops, can I go back? There we go. Fortunately, the final version of the common rule did not wind up having this hard biospecimen exceptionalism built into it, but it did create that broad consent that was created for that purpose, and left open the possibility that all future genetic information will be deemed identifiable, which might be a backdoor way into having that. And it's been pretty clear that the policymakers really thought that people saw these things really differently. And I know that because during the time they were having these debates about the NPRM, Rob Califf called me up and said, so what do we really know about the difference between those two? And we had to say, we really don't know the answer to that. Most of the people who study those two things either study one or the other, or both lumped in together, but we really didn't know very much about the relationship between them and how people view them separately. So we decided to actually explore this issue of biospecimen exceptionalism, and we wanted data about how patients and potential research participants view the differences between them, whether there were differences across racial and ethnic groups around how they viewed those questions. And it seems to us that that latter question is going to be especially important as financially stressed minority-serving institutions might lack resources to fully implement more robust requirements if you really embody those kinds of exceptionalist approaches. So this came out of something that we called the value studies, where we were assessing and comparing patient attitudes towards use and governance of clinical data and samples in racially and ethnically diverse populations, and identifying factors associated with differences in those attitudes. And this is a pretty broad project. I think I talked a little bit about this project 2 years ago when I was here, especially around some of the metaphor usage. But we looked at a lot of issues, but this was one of the core things we wanted to do in this research. And this research was funded by an R01 from the National Library of Medicine. And you can see the long list of collaborators from Stanford, from Sutter Health System, Palo Alto Medical Research Foundation, which provided the research participants for us, as well as Seattle Children's Hospital, and a group that helped make videos for us called Booster Shot. This research we had 20 focus groups of their patients, including 4 from each group. So four self-identified African-American populations, 4 Chinese populations, 2 were conducted in English and 2 in Mandarin, 4 Hispanic Latino, 2 in English, 2 were conducted in Spanish, 4 non-Hispanic white, and from now on I'm just going to call that white population because it's too hard to just keep saying non-Hispanic white over and over again, and then 4 South Asian focus groups that were all conducted in English. We had a total of 122 participants. A code book was developed from a priori codes, and then initial review of transcripts led to some more inductive coding. They were iteratively piloted, refined, each transcript coded by one team member, and then we did testing of rate reliability and got a kappa of better than 0.8 and did team-based thematic analysis. Now, as part of this research, we created these videos that we showed to people. We actually learned through the process of doing this that different racial and ethnic groups responded very, very differently to different metaphors for describing things. We got very different responses to a biobank versus, say, a data repository. People looked at those things very differently. We wound up calling it the Library of Medical Information. And as part of the Library of Medical Information, we sort of presented both how electronic health records and samples can both be placed into the library. And some of the results of the research I'm about to present have been published online in Genetics and Medicine, but it's not out in print yet. So we were probing for differences, asking them how they would feel about their electronic health record data being used for research explained in the videos that explain the creation and what the uses of the Library of Health Medical Information, and really describe what people can do with all this kind of research. And then asked how they would feel about their biological samples being used for the same research, so we could compare how they thought about electronic health record research with how they thought about uses of their samples. So a big chunk of the people thought that there was really no difference in risk and no really significant difference between biospecimens and electronic health records. I have, as a representative sample, I have no problem with the tissue samples or the blood. To me, it's the same as the data. And you can see this was expressed by at least someone in 19 of the 20 groups, and there were a lot of nodding, and so that was definitely represented by a lot of people. But there were other people who actually saw big differences between these two. So one concern that we saw expressed were that biospecimens are an extension of the self and require special care and respect. You can see this. I feel more uncomfortable with giving a biological specimen because it feels like an attachment or extension of myself. A blood sample or tissue sample feels connected to me, and that makes me feel more vulnerable because that was a direct piece of me versus a reaction to me. And then I think of the example of Henrietta Lacks, and I'm like, I don't want to be Henrietta Lacks. So we saw that very powerfully coming out by a number of individuals in 9 of the 20 focus groups. And then interestingly and very suggestively, that didn't come out at all in any of the white focus groups. Only in the non-white focus groups did we see that perspective being presented. In contrast, we saw some other folks who were concerned about sources of unjust profitability. And you can see that all of the white focus groups expressed that. There was even a little difference between the way that was cashed out. The non-white populations were worried about how this might lead to more expensive drugs or things that would hurt the population. Whereas what we saw when we tried to pick like all the representative samples for this kind of concern about them not getting their share, that was pretty much almost exclusively in the white focus groups. If they're going to pick 50 samples and yours happens to be one of them and they discover some world-saving drug and they make $1 trillion, where's your share of that because you helped do that? And we saw that kind of view in the white focus groups. There was worry in all of the focus groups, as you'd expect, about the fact that there might be problems of identifiability and risk to privacy, and that DNA made them more nervous for privacy and confidentiality. All of the groups expressed that concern. Interestingly, 8 of the 20 groups were worried about human cloning. Can you make another me out of that, right? I don't want that to happen. A clone, right? I don't want that to happen. And again, none of the white focus groups had that concern, but 8 of the non-white focus groups had that as a concern. Biospecimen use in research may warrant separate consent from EHRs. We wanted to look and see whether they thought they should be the same or different. Some people thought they should be the same, but some people said, yes, I'd like to separate the consent and make them differently, and we saw that distributed across them. So, I know I'm getting low on time, so I'm racing through. Basically, I think we need more data. This is only a qualitative study. So what we saw was very suggestive. What we could see is that lots of people see these things as the same, but that there are definitely at least some parts of the population that see them as very different. What we don't know and can't determine from a qualitative study like this is what the prevalence of those different responses are. So it's really imperative that quantitative work, like some of the work that I think is going to be done here, really explore that issue in detail to really find out what the prevalence rates of these different attitudes are and how they distribute across these different populations. But at minimum, this highlights that this is something that needs to be explored. The other challenge is the challenge of going from opinion and what people think about this issue to actually policy development and the normative conclusions. Some of the most prevalent concerns, privacy and confidentiality, suggest education rather than exceptionalism, because people who are more worried about their DNA than their EHRs are probably misguided, and highlights a problem with education and understanding rather than a problem of policy. But the suggestive pattern of other concerns suggests that there might be differences that could matter for recruitment of underrepresented groups in research. And I think this is especially important because some of our metaphors that we use for describing this tend to more focus on evoking the biospecimen aspect of things like a biobank, while others tend to focus more on the data. So if there's differential response in these different racial and ethnic groups, then that may be reinforced by the language and the metaphors we use when we're describing this research to those populations. And all of that needs to be explored in a lot more detail. Thank you very much.
Great, thank you. All right, thank you very much for inviting me to be part of this symposium, and thank you all for being here. It's really great to be here, and it's really interesting to see the many different approaches to the set of questions we've been talking about. So today, I'm going to do this, okay. Oh, thank you. Okay, so I want to talk about the challenge that user-generated personal health data poses for learning health systems. And the context for what I want to talk about is something that I think is familiar to everyone and has become more familiar over the past year, even if it wasn't previously, which is, we know that wearable devices and mobile apps and social media are capturing more and more, not just data, but health-relevant data broadly defined, right? So health-relevant is becoming a broader and broader category. And some of these data have a clear place in extending the boundaries of the learning health system outside of the clinic's walls, but how that's actually going to take place is not known at this time. So one of the core questions that's motivating my research is who benefits from integrating what I call metaclinical personal health data. So that is personal health data that's generated from somewhere outside of clinical settings into learning health systems. And so a lot of what I want to talk about and think about today is the tension between the ways that these data are captured and produced outside of clinical settings, which is usually enabled by technology companies, not health companies in some way. The tension between that and the interests and stakes of the healthcare system. So this is going to go back to some of the issues that were raised in earlier panels today. So one of the key issues here is that the novel achievements of user-generated health data, being able to understand better the impact of exposures, not just environmental exposures, but other kinds of exposures, which we could learn from these data that are being produced outside of clinical settings. The novel achievements of those data depend on participants' willingness to share their data, even when it may not serve their own best interests. And the assumption that sharing data is something that's going to be appealing to people whose health may benefit from it, as we heard earlier, is something that we can't take for granted. So my talk today is going to talk about the issues around sharing and trust and privacy that come up when we're looking at these metaclinical personal health data. And I'm going to draw on some recent research that I've done that looked at both recent, how researchers, so academic researchers, as well as startup companies and members of the general public interact with and understand the value of user-generated health data as a component of big health data. So the conditions of possibility for us to start generating these very large and potentially valuable data sets has emerged with the rise of user-generated content. So again, this is not unique to healthcare at all, but data from things like user reviews, restaurant ratings, as well as Facebook posts and self-reported health information in online patient communities has fueled this rise of big health data. And of course, the growing popularity of wearable health and wellness trackers has also created an abundance of user-generated health data. As I think everyone in this room knows, the data that are produced from these kinds of devices are produced, shared, and exploited under very poorly understood privacy and ownership policies. The terms of use for most of these wearables, most of these technologies, software as well, stipulate that the company can sell their data to third parties as they see fit in the course of business deals. And I think that many people became acutely aware of that recently with the Facebook Cambridge Analytica scandal. One of the major effects of the emergence of these wearable devices that can capture data outside of clinical settings is that the very concepts of clinical and non-clinical, or what I'm calling metaclinical spaces and practices, is being redefined. So lots of digital health startups are capitalizing on this phenomenon through software devices and services that work around the traditional brick and mortar doctor's office or hospital. So I think there's a point here for learning health systems, which is the question, what are the boundaries of the learning health system? In other words, are they the hospital's walls? Because most of what is going on outside of the hospital's walls would suggest that that wouldn't be the right definition at this point. So the blurring of boundaries between the clinical and the non-clinical, or between medical and health and wellness domains, may seem to suggest that the distinctions between these domains are becoming less relevant. But I think we need to recognize that the law that defines the regulatory boundaries between consumer-facing metaclinical software applications and devices, most of which do not require FDA approval, are not governed by HIPAA or really much privacy law at all, the distinction between that and then clinical-facing apps and devices, which are governed by a lot of regulations, is a very real distinction. So when we're thinking about how user-generated health data travels through social and information networks, the boundaries between these domains are actually still highly relevant, and they pose a significant barrier to integrating these data into learning health systems. So the claims of Apple Health about the seamless integration with EHRs notwithstanding, user-generated health data from commercial devices are not easily integrated into learning health systems. With few exceptions, user-generated health data presently has no place within formal EHR-based settings. So that makes it essentially invisible to the majority of doctor-patient encounters. Yet this is the kind of information that's being fed back to people who are employing these devices outside of clinical settings on a day-to-day basis throughout their lives. So the concern for the need to protect patient information through adherence to HIPAA guidelines, for example, has constrained in some cases the expansion of patient autonomy into clinical domains as new methods for sharing patient data enabled by electronic communication technologies have raised concerns around ownership, confidentiality, and control. This is recognized as a regulatory issue, in other words, the ways that these data are governed in different domains, but we need to pay more attention, I think, also to the cultural issues at stake. So in other words, the attitudes that people have about how they use technology outside of clinical settings versus how they use them inside of clinical settings. Oops. Let's go back. Okay, so health-related device and software companies that are operating outside of hospitals, clinics, and other HIPAA-protected zones face few restrictions on their sharing and exploitation of users' data. Consumers must agree to terms and conditions to activate and use the app, but in many cases, those terms of use permit the parent company to sell that data with third parties. But does anyone here read terms of use? No one does, and that's one of the maybe a couple of lawyers in the room do. They're always the only people who do, and even then, when pressed, they usually say that they don't really. But that was one of the questions that our research was probing, was whether people read terms of use, and especially how this relates to how people think about consent for clinical research. So that's where we're going with this. Now, the Facebook Cambridge Analytica scandal gave us a pretty good idea of some of the things that may happen to personal data, which includes health-relevant data, but also includes a lot of other data on at least one very widely used social media platform. But perhaps paradoxically, some users are much more willing to share their health data on an app and even on a social network that they know exploits it than they are with their healthcare provider or with a clinician researcher. Now, one aspect of this is that the socio-technical infrastructure of most apps builds social networking capacity into product design and marketing. So the barriers to sharing user-generated data within those settings are very low, whereas the barriers in clinical settings are really quite high. So, as I was just saying, so there's a contradiction that's emerging when we start to think about metaclinical health data as it might inform what happens in clinical settings, and that is that There's a very restrictive view of data sharing within medicine, narrowly defined, and there's a very permissive view of data sharing outside of medicine. And this cultivates a sense of uncertainty among users about the value of privacy and trust on the one hand, and openness and sharing on the other. So there's an asymmetry of opportunities for user-generated data to serve the goals of patients inside versus outside of clinical settings. And this points to the conflicting conceptual models that characterize these ecosystems today. So although the Pew Research Center and many others have found that most Americans will say that they strongly agree that maintaining their privacy and confidentiality in everyday activities is important, in our research, few of the people that we interviewed expressed these concerns. When we asked whether they were concerned that their data was being used for purposes that they were unaware of, one person said, "Do I ever read terms of use? Did I actually read the consent form I just signed? No, I just agree to everything like I do for all of my Apple updates. Agree, done, so no." Almost all of our interviewees agreed that they might have shared their health data with third parties without being fully aware. One of the surprising results of our interviews, and I will say these interviews were done before the Facebook Cambridge Analytica scandal, but I doubt that the results would be all that different right now. One of the surprising findings was that despite the constant reporting of large-scale data breaches around the world, our interlocutors felt little concern about sharing their user-generated health data with corporations. Why is that? Some of them suggested that the transactional nature of their consent overrode concerns about privacy, which is to say they had already decided they wanted to use the app or the device, and so they felt like they just had to agree. Joseph Turow and others have called this the trade-off fallacy. In other words, if you want to use the thing, then you have to give up your data. And this fallacy is a major issue for privacy in the digital age in health contexts. So alongside the widespread perception that it's impossible for users to opt out of participation in surveillance practices, the rhetoric of personalization and sharing in social media facilitates an understanding of user-generated health data that de-emphasizes the risk of exploitation in favor of loosely defined benefits to individual and social well-being. In this model, the concept of personalization emerges from the purposeful creation of networks of family members and friends with whom individuals share data willingly to motivate themselves or make their data tracking activities more social. So the sense that each of these networks is highly personal to its creator seems to be one way that the awareness of other less benevolent entities' involvement is overridden. Yet health systems are implicated in the lack of protections for patients, even as they're guided by the strict regulations and penalties for violations that are established by law. So just as an example, in 2016, Facebook was sued by a metastatic cancer patient who accused the company of violating his privacy by collecting data about his participation on cancer websites outside of Facebook. And you'll note that some of the defendants that were named include the Cleveland Clinic and the MD Anderson Cancer Center. The case is currently under appeal, but this has clearly not stopped the company from pursuing data initiatives in healthcare. In June 2017, Facebook convened drug marketers at the inaugural Facebook Health Summit to try to get more pharmaceutical companies to advertise on the platform, basically. And one of the ways that they did it was by creating a new feature just for this sector that allowed them to turn off the comments on their brand pages to sort of control more the kind of dialogue that might occur around their use of the platform for advertising. And this is, I'm using the Facebook example, but this is not just about Facebook. This is just sort of the case that I'm talking about right now. Mark Zuckerberg, when he was being questioned by Congress, claimed that he was not fully aware of everything that happens in the Facebook digital economy. But there are reasons to believe that healthcare information may lead to the next big data-related crisis outside of clinical settings. There was reporting about Facebook trying to get hospitals to give them information that they could de-identify, and one of the people that was interviewed about that issue was Kathleen Gates, the interim CEO of the American College of Cardiology, who was pointing to the exact same reasons why learning health systems want to incorporate other kinds of patient data in order to learn from them. So the idea that people are sharing information about themselves online in ways that may determine how to improve their health, and that there's an opportunity here for improving health outcomes. So that is a real desire that is shared in both of these sectors. So this is a reason why I think these kinds of issues and platforms like Facebook really need to be thought about here. Okay, so if you consider the large number of patient support groups that are on Facebook, for example, this is a list of just some of the types of personally identifiable information that are readily available for mining on one particular breast cancer support group. There are more, but I think you can see there's a lot of fairly personal information there. When I was talking about this 6 months ago or so, someone who was in the audience happened to be a moderator of a Facebook group, a different breast cancer group, and it made her start wondering, and she started looking at their group, which was a private group, and they found an extension for a Chrome browser that was being used to scrape data from this private group. So again, it's not just Facebook, but this is just to say, and this isn't a computer scientist who's doing a deep dive on this platform. Okay, so the point I want to bring home about this for the learning health system is that the way that we talk about research participants plays a huge role in how people feel about sharing their information. Being consented by agreeing to terms of use on a platform doesn't make anyone feel vulnerable or at risk of being exploited. But asking people, using the consent protocol and highlighting the individual's role and what their risks are plays a really significant role in raising people's concerns about privacy and trust. So we found from the people we interviewed as well as the researchers we interviewed that the explicit description of protocols for data privacy, security, and storage, what you have to do when you're consenting someone to participate in research, narrates the threat of malevolent data exploitation while promising not to do that. What this means is that we have competing models of privacy, one that emphasizes threat in the clinical setting, one that emphasizes benefit in the metaclinical setting. So to wrap up, some of the key issues that I think come from this for learning health systems, metaclinical health data is entering clinical ecosystems, among other things, as training data for AI and machine learning systems. The conversion of social determinants of health into digital biomarkers in these contexts is being used to determine patient risk profiles. There's a lack of transparency about how these categories of social determinants of health are being used in these settings. And there's a huge contrast between the culture of medicine and the culture of technology companies and how people interact with them as either consumers or as patients. So we need greater transparency in the use of metaclinical training data. Patients need to understand what's being done with their data and have the option to opt out. We need to identify levels of data sharing that may be available to participants in research. And we need to think more about aligning consumer-facing terms of use and clinical consent and how those two domains relate to each other. Thank you very much.
All right, so you're about to hear from a whole bunch of people in a very short period of time. Give each of us 2 or 3 minutes, and we may go over a little bit, but it should be okay. As I'm doing this, I'm hoping that Zach, Mina, Gracie, and Ray will start making their way up here. But what we're going to do is go over what we did yesterday, which was a writing sprint. I'll tell you what it is, why we did it, and then they'll proceed to tell you what they actually did. So writing sprint is a methodology that was developed here at University of Michigan at IHPI by Andy Ryan and colleagues, and Verhey Henke at the School of Public Health, to basically provide an opportunity for people to, in a semi-structured way, advance a manuscript or a grant from some state of conceptualization into realization. It's a way of sort of avoiding this blank screen and the blinking, we've seen that, you know what that is. The blank page. There's a fairly flexible format. We recognize that ELSI is a very interdisciplinary set of teamwork, and so it sort of lends itself well to this kind of collaboration. And one of the things, at least I was interested, is whether or not this kind of a method or activity during a day would be scalable to other sort of contexts, and maybe next year have it open it up to other folks. So we had 3 papers and 1 grant that are all at various stages of development, which you'll hear. One group that was led by Zach Landis-Lewis, considering the ethical considerations for performance feedback interventions to healthcare professionals and teams, an application of critical race theory and public health critical race praxis to ELSI-LHS, and that's work that we're working on with Melissa Creary and my team. My research team, the deliberative democracy as a development of engagement in health and science policy, and then the final group started working on a grant that we hope will fund future years of this symposium. So Zach, if you're ready, please come tell us what you did.
Thank you. I'm glad to share this work we're doing about performance feedback to healthcare professionals in learning health systems. And we had a first writing sprint yesterday, so we're at a stage of a detailed outline. We've done some literature reviewing, and I'm working with Janice Fern as well as some graduate students. And I guess the focus here is on work that's going on widely in healthcare organizations to build clinical quality dashboards and feedback reports that push information to healthcare professionals. This can be very valuable for problem solving and learning to improve practice, but can also carry assumptions about the meaning of data and measurement practices that drive documentation and things that are unintended consequences of these kinds of systems. So as a software developer and system designer, I know that these kinds of problems can be built into systems, can scale up, and are important to consider. And that's really the focus of our topic, is to understand what is the domain of relevant ethical foundations that we can draw on, what are the key principles that we should keep in mind. We've done a little bit of literature review, and we're drawing on areas of intelligent systems and automation, health communication and promotion, as well as learning health systems frameworks like the Faden framework and other foundational work for this area. So our goal here is to outline the key domains and call attention to this as an important aspect of systems development in learning health systems. Thank you.
Hi, so my name is Meena Raj. I'm working together with the team that's mainly sitting in this corner of the room. So Elizabeth Cope, Melissa Creary, Paige Nong, Jody Platt, myself, and Gracie Trinidad. So we're working on, it's more of an analytic essay, is probably the way we would classify it, looking at ELSI-LHS, a novel application of critical race theory. And just to give you a little glimpse of our process, of course, this hides a lot of the strike through and the unstriking through and the comments that are on the page. But so we've really been working on this for a few weeks now. And so gone through a few collaborative sessions of writing together, rotating our roles and reading each other's work, and providing feedback, brainstorming. And so the idea for this paper actually captures what Kate started off the symposium with today, and then was brought up by a few speakers in the second panel, and some of the really great comments and questions that came after that, with the idea of these built-in biases. And so the LHS is kind of at risk of exacerbating some of these biases that we see. And so we need to start emphasizing kind of the social and humanistic components to go along with the technical infrastructure. So in this, we use Chandra Ford's public health critical race praxis and apply these principles that she brings up to the ELSI-LHS. With a focus on bias and discrimination. So we illustrate this using the case of pain management. And so some of the key conclusions we've come up with are that we need to start identifying stakeholders and really understanding how they collaborate and how they engage with each other when stakeholder groups are coming with unique, diverse, sometimes conflicting perspectives. And additionally, and this, I think this was brought up in the second session as well, how we can come up with research questions and do research that's also informed by patient perspectives and the communities that we're hoping to serve. Thank you.
Hello, I'm Ray DeVries. I co-direct the Center for Bioethics and Social Sciences in Medicine. In our little sprint, we're trying to deal with one problem, and I think it was evident today in some of the talks, that the ghost in the LHS machine, if you will, is the public. How do we involve the public in what we're doing? And how do we make them more than just a ghost of our imagination about what they might think or what they might say about how we're collecting information in LHS? And there's several ways and as you've heard, we can talk to them, we can do focus groups, we can do interviews, we can survey them, we can use Mechanical Turk, we heard about that today, we can use panels, we can do random digit dialing surveys, but there are problems with all of those, right? And first problem for all methods are representativeness. Are we getting a representative sample? But a second problem, peculiar to what we're doing, is when we survey people or talk to them or interview them, do they really understand what an LHS is? And we just heard from my colleague here, he's been at this for 3 years, and he's just starting to understand that. So one method for doing that is deliberative democracy, or deliberative methods are called by several different names. And there's so many ways to do that, but basically the process is you recruit members of the public, you educate them, because these issues are complicated, you have them deliberate around a certain set of issues, and then they come and talk about what they've learned, and they give you some sense of how they feel now that they know a little bit more about the topic and they've heard some about the topic. So we've used this method here at the University of Michigan. I've been involved with projects looking at, should we have surrogate consent to enroll demented people in research? I've also looked at how do the public feel about using their donations in biobanks, or how does the public feel about their information being shared with commercial companies? These are all things we've done. But if you look around the country, if you look around the world, people are doing this in a whole bunch of different ways, all of which have strengths and weaknesses. So a couple of months ago, we brought a bunch of people together here. My center sponsored that meeting. And we talked to them about, hey, how are you doing deliberation? How are you doing deliberation? What are some of the problems with what you're doing? So the paper that we're working on is basically an effort to try to bring some clarity and maybe move us ahead and learn from each other about what we're doing. So kind of like trying to create the democratic deliberation 2.0, if you will. So this is what more or less what we came up with, but let me briefly summarize it. So we're building this paper, and what we're trying to do to learn from each other is asking a bunch of who is questions. So basically what we're saying is, okay, when you do a deliberation, who's asking? Who wants to know what we're asking these people to do? And of course, part of that, who's funding it? And then part of that too is how are they asking? So for each of these who is questions, there is a how question. The second thing is who is talking, and that gets at the issues of recruitment. How do you recruit the people who are there? How do you organize what they're talking about? The who is talking also applies to the educating. What kind of education are you giving people? Is that somehow non-biased education, which is a problem? Who is listening? That is, who cares about what's going on here? And that leads to the fourth point, which is who is responding to the results of these deliberations? How is this information being used, translated, and disseminated? So we're on our way. We had a very interesting 2-hour conversation, and we actually, if you look at this, we actually allocated certain names to certain topics. So, within a couple of months, I think we might have something that you can all read somewhere. We'll let you know. Thank you.
All right, I'm the last one. So our group worked on getting more money for this symposium. Yeah, and this is the second year that I've worked on Jody's team in some capacity on this symposium, and I think it's one of the most fun symposia or conferences I have attended, and I think that's not just because I'm part of the committee, but I think it's a fun group. So our group really wanted to figure out what the ELSI-LHS practice looks like in future symposia, what our outputs would look like in the future, so papers, grants, other materials, what groups we wanted to reach out to, and brainstorming future ELSI-LHS themes. So if you've noticed, every year has had a very specific theme, and what do those themes look like in the future? So this is kind of a glimpse at what we worked on. It was an incredible conversation to have in a writing sprint because it really, bringing people in the room together who had different approaches to ELSI or different understandings of what ELSI meant really forced us to articulate very clearly what it was ELSI in our domain or in our, what we believed it should be. And to really articulate what makes this symposium and this community particularly unique in the ELSI ecosystem that exists nationally. NIH has a bunch of efforts. So it was a really valuable experience, and I really think the writing sprint format worked for this particular grant effort pretty well. So the outcomes of our meeting, our long-term goals was to articulate why the U of M approach to ELSI-LHS is actually unique. And then we kind of summarize the results of the meeting as a focus on building infrastructure and systems that enable the equitable generation and sharing of health data. And Brendan Delaney had a comment in our meeting that I think really said this well. It was, the critical thing is designing the system to address ELSI concerns from the outset. I'm paraphrasing, but basically it's what you said. That if you go ahead and build a system without being informed of the ELSI aspects, you're missing out. It's not like we can go back and build ELSI into a system and that happens in a graceful way. For building systems, we have to also take into consideration all the topics that we were speaking about today. So potential topics, translational team science. Dr. Collier brought up citizen scientists, what is included in an LHS ELSI pedagogy. And also, why is this different, or how is this different from EISI, AI, and PMI? Outcomes would be evaluation of the pedagogy, generation of ELSI-LHS resources that reach beyond this community, beyond the community that's already interested in ELSI and into clinician work, clinical work, the healthcare setting. And the potential innovation of this group are panels that include empiricist practitioners, ELSI, and patient representatives. Kind of got that going on, but to make that a national thing. Experiential learning, there's a comment about simulations that can help people build empathy. PhD and MS programs, that's me. And then building ELSI values into care and data outputs, and building ELSI into the global health agenda. So thanks so much, you guys. It was a really fantastic conversation. I really love this symposium. Looking forward to getting more money for it.
Thank you to all of our writing sprint presenters. If you were part of any of the writing sprint groups yesterday, can you stand up and so we can thank you for your participation and time? And we'll appreciate feedback too, because it's something that we want to think about doing again. So now we're going to turn to our panel, and I introduced Dr. Reshma Jagsi earlier, and she's going to be our first discussant. And then we'll open it up, as we have in the other two sessions, to the rest of the room. And if there's any questions for any of the writing sprints as well, while those folks are not here up at the up in the front, we can run a microphone to them and they can answer your question as well. Reshma.
Thank you. So I just want to thank Doreen for that lovely introduction, and Kate and Jody for inviting me to be here, and all of the organizers. One of the real treats since I started directing the Center for Bioethics and Social Sciences in Medicine just a little over a year ago has been the growing relationship that we've seen with the Department of Learning Health Sciences. And I saw Chuck sitting in various places in the room, but I just want to say how wonderful it is to be at an institution where there has been so much groundbreaking work done in this area that impacts health health so broadly. And it's so wonderful to be here and hear about all the exciting work that's going on in this area. And so I'm charged with, in just a couple of minutes, tying together what was billed as 3 talks, but actually appears to have been 6 extemporaneously. So I'll try to tie that together as best I can. And what I've heard is the shared excitement about the promise of learning health systems, and yet concerns about the way that to date we have gathered relatively unconsidered reflexive judgments of the public about the ethical issues involved. And we have certainly seen some really powerful preliminary results from studies that have used methods like focus groups. We ourselves have conducted studies that have interviewed patients with cancer about their opinions of learning health systems. We've conducted surveys, and we've had some very similar findings to what David presented, where we've observed some racial and ethnic differences in attitudes here that are quite understandable where these are coming from, but that deserve further exploration. And we've also seen some curious distinctions that have been brought up, right? So David brought up this biospecimen exceptionalism, which seems a very curious distinction between data from electronic medical records and data from biospecimens, right? And we've also heard about this distinction between data that come from metaclinical versus clinical applications, and the framing effects there and how important these are. And of course, we know that from static methods, traditional social scientific methods of measurement, surveys, focus groups, interviews, we are very vulnerable to the framing effects here. And so I do think that the promise here is particularly taking this forward with the deliberative methods that we heard Ray describe, and that was the focus of the third writing group. So we ourselves actually here have been leading some work in this area. I'm the PI of an R01 grant from the National Cancer Institute that actually is going to use deliberative methods to try to understand what the considered judgments of a representative and diverse sample of patients would be. And so in that way, engage those diverse perspectives of patients collaboratively, as we heard from the second writing sprint group, is such an important endeavor. And so I think that hopefully we will then move forward with building ELSI considerations into these systems from the outset, as we heard in the fourth talk. And I'm just at a loss to build in the first talk. So I will say that we've heard a lot of really exciting things, and that there is so much more going on. And the best thing is to hear how we're looking to take this forward with grant writing to support more gatherings of our colleagues in venues like this, but then also the kinds of research that is ongoing to bring in diverse groups of patients. And I especially loved the concept of bringing in the patient voice into this room as well in future years. So thank you for inviting me to comment, and thank you for your thoughts. I look forward to hearing them.
Thank you, Reshma.
Thank you for your presentations. I was wondering if part of the disconnect between the public's willingness to share their information in social media versus health services could be related to something as practical as the fear of not being covered by their insurance for pre-existing conditions. So the implication of sharing that data could affect their ability to actually get care in the future.
Yeah, so that's a great question, and I think it really gets at the heart of the misunderstandings around what spaces are safe spaces to share personal data in, and which are not, because people are sharing that data on social media, and it's fully available to data brokers who sell it to insurance companies. So it's again, but it's not. But your participation in Facebook is not framed as posing that risk, right? Whereas your participation in health research to explore whatever is framed as putting you at risk for something specific, and it's laid out in front of you, and you're called out as an individual who's participating rather than as just one of many who clicks through this very generic thing, and it's not brought to the fore. So that's why I think that the framing around how we think about what happens in these different domains and what the risks are is really important. And I really hope that some perspectives from from healthcare get into the debates about how these tech companies that are, even though they're moving into healthcare, they're not treated as healthcare providers or as part of the healthcare industry. I really hope that still perspectives from healthcare get into the debates about regulation of their data, because if they don't, it's going to leave a huge loophole that will, allow the continued exploitation of this kind of stuff.
This is I guess a follow-on on a question that I asked earlier, which is looking at the graph, Kirsten, that you put up, the Crohn's database, and just where in the world people were providing data. There were fascinating patterns there. Like, you might think, oh, Europeans aren't going to share data as much because they care about privacy more with respect to private industry, but it turns out there looks like a ton of data coming from Europe. But there are chunks of the world where there's really not anything, and those kind of match global north-south, but not entirely. And I was curious if you had done any work or knew of good work about kind of how these ideas and the concerns about framing and metaphors shift across national or international borders.
I can speak about that last issue. It's really, even studying metaphor within a single culture or a parent culture is complicated, and there's different theories about how to understand what that means, but it's definitely challenging when you cross languages and cultures. When we were working on creating the videos for the Library of Medical Information in Mandarin, it was really challenging, both because in Mandarin and in our videos, we had both spoken and written, and those don't match up in quite the same way. We also couldn't use the concept of the library in the same way, because the Mandarin word for library is just place and book put together, and that didn't really capture what we were trying. And when we did, and it's preparatory to creating our videos, when we did focus groups with individuals from that community, they basically said, you really want to call it a database. And so, but then that makes it challenging to do these comparisons, because really we're using a database metaphor when we're talking to people in Mandarin, and Library of Medical Information when we're doing it in English. So I think it's really, really challenging. I'll just say one last thing about metaphor. In the end, anytime you're having communication between experts who have one set of shared assumptions and backgrounds, people with one background and people that don't, communication, I mean, people who study this all the time, something that I'm doing a lot of studying of physician-patient encounters, but really when you record conversations between people, it's really just a string of non sequiturs that only makes sense because of the inferences people are making about the intentions of the speaker. So that's a very Gricean view of things, but that's how I think that communication is. That works great when there's a lot shared. When there isn't a lot shared, when you have these dichotomies between like researchers who come from one world, very different from the people you're speaking with, then it's an invitation for misalignment and miscommunication that I think is actually ubiquitous in interactions, both in clinical settings and in the recruitment of participants for research.
So I'll just add that the map from chronology may not map exactly to the global map of, say, social media use, which is growing quite a lot, although globally, worldwide right now, a little over 50% of the total global population uses social media, just the total global population. And that is distributed not entirely, but similarly to that map. However, the different forms of digital connectivity that exist worldwide are growing rapidly, many different kinds in different places. And I think that so in different places, there might be different models for exactly what kinds of platforms. The chronology is it's a patient-generated community, right? Whereas Facebook just takes all comers. But I think that there are increasingly spaces that are popping up in many parts of the world that are, if they're not being mined in this way now, often because maybe the healthcare system itself is completely different in terms of the role of insurers and payment and all that stuff, it still opens up that exact same vulnerability. And we have seen that already in the ways that social media are used for political purposes. In like the Facebook Myanmar example is a classic one. So I would expect that those kinds of risks would come about in those settings too, but they may just follow really different paths.
Thank you both for these talks. So I had a question in regards to what you were talking about, Kirsten, in terms of the user in the breast cancer support group who found that their data was being scraped. Are you finding any information that shows that users are responding to these privacy concerns, or their investment in sort of the work of kind of producing these kinds of data? Are they organized or any particular media practices? Are they using particular technologies or apps to sort of demonstrate this kind of investment, or is there any work sort of paying attention to that?
Yeah, so actually, I'm glad that you asked about that, because I should have included the follow-up, which is that, so her group, which is a BRCA group, they organized, they're based in California, and they organized and approached Facebook and said, we found out about this and we don't like it, and we would like you to do something about it, and nothing happened for a little while. And so then they went back and they said, no, we're still paying attention, and we see that this is still happening and this is a real problem. And they pushed for a while, and they got Facebook to do something that changed the ability for that particular plugin to function on their group. Now, that doesn't mean that no one else can get access to the data, right? But it is a small example of how that kind of pushback can lead to certain kinds of changes. And I'm also intrigued by the the activities of the Google employees to push for different kinds of ethical changes internally to Google, which I think is actually quite relevant to the conversations that are going on in this room in terms of, that is not a group of healthcare workers, yet what they do about privacy and ethics and equality within that tech company will have huge implications in the healthcare sector. So I'm not sure if that totally addresses your question, does it? Or was there another piece? Okay, I see what you're saying. Most of the patients that I've talked to who participate in these kinds of groups feel like it's pretty unavoidable, and that the value of participating in these groups, not just for social support, but raising awareness about available clinical trials or different kinds of lifestyle or diet shifts that might help them manage medication side effects, those kinds of things. They see them as lifelines. They use that term over and over again, in terms of metaphors. So the idea of, no one thinks that there's some safe space out there where you're invulnerable to these kinds of practices, but they see the trade-off is worth it, and feel very unhappy about that. So there's definitely an opportunity for better practices to emerge. Yeah. Kate.
Hi. So one of the things that I was struck by through many of our speakers' talks is this space between how we as researchers expect participants to respond and then how they actually tell us they feel, right? I'm consistently sort of surprised. So for example, in Michelle's talk about when we were surveying people, would they prefer to be part of an A/B trial where there was equipoise, or just be experimented on in quotes, every time because the doctor doesn't actually know what they're doing? Or, to David's point, people feeling very differently about specimens and data, not necessarily because you can sequence the specimens, which would make sense to me, but just because they feel differently. Or to Kirsten's point, that people are more trusting of social media platforms where they get something back, but much less trusting if I have to give them a 20-page informed consent form with like a 40-page IRB. And these are all examples of people sort of acting in ways that don't make sense to us. And I was wondering if you had any thoughts on some sort of overarching theories of why we might not be understanding, like what's going on in these thought processes that we as researchers aren't understanding.
So I think some of this may be related to framing and the lack of time for individuals to consider all of the issues involved and consider the opinions of their peers in the community. And so that is why I think that it will be very interesting to see what the results of deliberative sessions where people are not asked in a short period of time to respond with one type of framing, but are actually given multiple frames, are framed on threat and framed on benefit, where we have plenary speakers who talk about all of the promises and the potential benefits directly to them, and they sit at tables and they talk with others and a diverse community. So to take the focus groups that were conducted where individuals from the same community are talking with one another and having these views, but now bringing people together where each table has representatives from different perspectives and interacting with each other. I think it's very important to see whether those considered judgments after deliberation actually evolve. And so what we do with deliberative methods, as you know, I mean, you've been involved in our work, is we'll measure their static opinions based on surveys that that likely do show these curious dichotomies and things that we find unexpected, and then we'll be able to see over the course of their deliberations whether hearing the thoughts of others and seeing the different ways this can be framed actually leads to different considered judgments at the end.
I think I disagree a little bit. So partly because I'm not as enamored of deliberative democracy as a methodology. I think it's a perfectly fine tool to have in the toolbox, but it's I worry a lot about the what exactly you're trying to get at. Like, so even if it turns out that, say, people from one community that feeling comfortable and other people with a similar community express something, then you put them in a different community where you're trying to get them to talk with each other, and even if they do to some extent and they don't say the same things, I don't know which represents their real views. And there's sometimes a suggestion that there's some legitimating function of the deliberative democracy approach, even though nobody really explores whether it's replicable. So if you got the same sort of group and you did it again, would you get the same outcomes? So I have some doubts about exactly what deliberative democracy is supposed to show. But I'll say one advantage of the approach is it's one way of solving what we call the Emily Latella problem, right? Which is, I don't know if anybody's old enough to remember, Emily Latella was a character for Gilda Radner on Saturday Night Live who used to say, what's all this talk about the death penalty? Don't deaf people have enough problems without having a penalty on top of that? And then would get corrected. So one of the worries is especially about understanding if we do these surveys and ask people about their views about euthanasia, and 20% say we're spending too much time talking about the youth in other countries and not enough about youth in America, you haven't really, it's not very informative. But there are lots of ways besides deliberative democracy to solve that. That's why we developed those videos to try and do that and did some testing to see how much understanding there is. So I think you can avoid the Emily Latella problem. And so I don't think that's not enough to justify having a deliberative democracy approach. But I think ultimately why we're so surprised by all these results, people, I think that it highlights the fact that people I'm constantly amazed when you talk to people from different backgrounds about their life experience and almost everything about them. Our focus groups where somebody said, we're talking about research. And I remember one woman saying, when I was a little girl, I wasn't allowed in the front door of this hospital. But now you're coming to ask me about, participating in research in this hospital. The experiences, the backgrounds are so radically different that it leads to all kinds of things. I was shocked when I was a long time ago when I was working at Penn, when I was the faculty member at the center there, to find out that our receptionist thought that AIDS was a conspiracy to attack the Black community. And it was like really interesting that she's working at a bioethics center and she's, people come from such radically different worlds, and it's really easy to be polite in different ways so you never see those things. And so I think some of what we're being shocked by is just why we have to do the research, because it's not that we want to, I worry that deliberative democracy is a way of sort of papering over what are in fact people's real responses. Some of it means education. Human cloning, probably not the most important thing to worry about with these samples, but there's something real there about the fact that this seems part of them in a different kind of way that we can see in this that I think is really significant and we have to take really seriously.
But sorry, can I just respond directly to that? Just because I think that that is, some of the things that we're trying to get at through improving the deliberative democracy method is exactly some of the questions that you've raised. But I do think that there is some value to the individual as well as the group responses at the end. So I think that what you're calling out is that certainly the group votes and the discussions are not the be-all and end-all, but that it's incredibly important at the end of deliberation to ask people, how much did you agree, how much was your voice heard, and then what do you feel after deliberation, what do you individually think? And not that any one individual can ever be a representative of the community from which they hail, but if we include enough individuals with those diverse life backgrounds and experiences, and after engaging them in that reflection with their with others, ask them what they think, I think there's value to doing that.
Value, but run it more than once and see if you
Agreed.
get the same outcomes, and I'll
Agreed.
feel a lot
Agreed.
better about the
Agreed.
methodology.
Agreed.
I'll just add a little point, which is I think this really speaks to knowledge hierarchies and kind of the larger institutional values that are embedded in systems that have existed for a long time and that change slowly when different parts of them change, but they don't change all at once, right? So it may be that asking patients to be part of different kinds of committees in a hospital, for example, may inform certain practices that may be helpful, but they may still feel like the overall approach to them is very paternalistic. And so those two things just don't line up. And so it is a larger kind of culture and perception problem, I think, that goes way beyond, one particular domain of research. But I think it also points to the fact that in thinking through how to get patient perspectives or just participant perspectives in, from the beginning, as one of the speakers talked about earlier, that makes a difference. But the entire context around why they should think this will lead to anything different, I think it has to be considered. And again, it's not as though these individual research projects can then address all of these social structures around a person's life that may factor into it. But if we act as though those factors aren't part of their experience, as if healthcare isn't part of the rest of the world that they live in, then I think we're going to constantly miss over and over again where the other priorities are that are making them, just think differently about what it would mean to participate in research.
Alan?
Yeah,
Stand up.
sure. Alan Flynn, Department of Learning Health Sciences. So I was thinking about, from an information science perspective, this idea of biospecimen essentialism or exceptionalism, and comparing that to the EHR record. And it occurred to me that we can think about a specimen or an EHR record as two different material manifestations of some information carrier. I mean, at that level, there's information being carried in both ways. But I think there are some real differences that may be what's really coming out in the research. So, for example, it seems to me that a biomedical specimen may have more durable information about me that's much longer lasting and permanent than information in the record that I can say that's no longer relevant 6 months later or 12 months later. But that specimen, the information in that specimen may actually be relevant for a very long time. And the information in that specimen may be much more actually than is carried in an EHR record. So harder to deny what's there potentially. I think that's one dimension that we should be thinking about. And the sheer quantity of the information may be driving some of the differences that you're perceiving.
I mean, the focus groups were fairly open-ended, and it's interesting. Those are good, all legitimate reasons for thinking of those things somewhat differently. That's not what we heard in the focus groups, though. So I think it is telling that even the perspective of, which makes sense if you're thinking about it as a data management process and then as just different sources of data, then you'll look at this differently than how the patients may look at that. And so I think that's important.
Go ahead.
So I wanted to follow up as well with one of the pieces in the focus groups that got brought up was the monetary piece, right? So I was curious, putting your two talks together, that data is being sold all over the place, but that the public at some point may have known more about monetizing biospecimens through more VUC Regents or Henrietta Lack's book. And so I was curious whether that monetary was brought up at all on the data side, and if not, whether you think that was just because they weren't sure of it or that they didn't care about it.
It was discussed, both were discussed, but it was much more of a concern for the DNA or for the biospecimens. And I'm not sure I completely understand why. I mean, in a different paper where we talked about the responses overall, there was the concerns about commercialization and commercial uses. So I didn't talk about this here because it didn't cut across the two. That was something that was found to be a problem for both sets of things. What was different was this notion that we only saw about the biospecimens, especially in the white focus groups of like I should get my cut. We only saw that notion that I should get my cut around the biospecimens, not about the data. But the concern that there's commercialization, that was ubiquitous across both data and specimens, and the worries, especially that this would lead to higher costs, that this would be all kinds of problems with commercial and mistrust of the commercialization. That was all published in another paper, and that didn't differentiate between those two, but we definitely did see that.
Any additional questions from the audience?
Wait, can I just follow up on that? Did you not ask whether people wanted to get their cut of data, or somebody just didn't happen to bring it up? Because I'm just wondering whether that's an actual contrast or whether just something that didn't happen to come up in those focus groups. Because that would be pretty interesting, right? If people are only concerned about getting a cut of specimen research as opposed to data research.
Yeah, I think that's just what emerged.
Got it.
This concern of like I should get my cut.
Right.
We never asked, do you feel like you're entitled? We didn't
Right,
probe for do you
right.
feel like you're
So
entitled.
it didn't happen
a
to
cut of-
emerge in the data conversation, which doesn't necessarily mean that people didn't feel that way about their data.
Correct. It
Got
just didn't emerge, and it emerged primarily in the white focus groups around data.
Got it. Thank you.
That's why this needs more follow-ups and a quantitative study.
Thank you.
I think one of the challenges for doing research in this area right now is things are changing every single day. Facebook and the society's understanding of what data can mean in politics, that your DNA information in a database is going to help the FBI catch Cousin John, who is a serial killer who you've never met in your entire life. I think our society is learning more and more every day, so it'll be interesting to see how that learning affects their opinions and views that maybe they didn't care last week, but maybe they will care in the future.
Our data was also collected prior to Cambridge Analytica.
Yeah. So times they are a-changin'. So thank you very much to our spirited panel. All of you were wonderful, and to Dr. Jagsey for being our discussant. Thank you for coming. I'm going to introduce our last two leaders of our symposium today who are going to have some closing comments, but a lovely University of Iowa healthcare pen has found its way up here. So if this is yours and you want to take it home with you, just find me. Anything that's got maize or yellow with anything other than blue gets tossed, so it's not going to survive. So next I'd like to introduce the two ladies who were most responsible for this wonderful symposium that we've had today, Dr. Plott and Professor Spector, who are now going to give closing remarks, and we are going to maybe even end a few minutes early.
No, you didn't. You didn't break anything at all. We're doing great, and I think we will get out a little bit early today. And anyway, the slide that's missing is the slide that says "Update Kate." So I think I'm just going to do that, and then when she's done, I just have a few quick closing remarks, and then we'll leave. There are evaluations on your table, so just start shuffling around, and there's other things on your table. So just we're getting ready to go. And just we'd appreciate those on the way out. So Kate, how do we do today?
Sure. So first of all, the complaint that I've gotten so far is that I was supposed to really emphasize that you're supposed to be writing on your tablecloths, and we had some lovely and supportive staff members and students make those tablecloths for us, and I was derelict in my duty to encourage you to use those awesomely colored Sharpies. So because you're supposed to write thoughts, feelings, ways for us to bring in more money, And so if you have any of those things, take the 5 minutes that we're giving back of your life from this conference and write something down, and that would be great. So the other sort of unenviable assignment I got given was trying to do a thematic summary of today on the fly. And Dr. DeVries has trained me well in the methods of qualitative research. So I'm just the themes are just gonna speak to me, and that's what qualitative research is, right? They just rise from the ashes. So I've got two. So I would say the first one is just this awareness of inequitable impacts of seemingly value neutral decisions. And I think we had a lot of observations in this space. So Dr. Nalia on whether they should try to limit missed appointments in their dental clinic by zip code and what sort of implications that might have that might go above and beyond and broader than what they were trying to do, which was not hurt their baseline, but actually start to hurt their patients. Or Professor Prince on exploitation of wellness programs and how these things might actually transition into sort of learning business systems as opposed to learning health systems, depending what the goals of them are. And Professor Collier on the need for both diversity in data banks, which I think we hear with some frequency, but also in how we're defining that diversity, which I think is a point that's not made enough and I think was very well taken. And then the sort of second overarching theme that I thought of, that I think a lot of people touched on, is this tension, this inherent tension between regulatory structures that we currently have and our clear best practices for how we should be conducting sort of our pragmatic and our learning health system trials. So there's obvious things that we should be doing, and then there's really obvious laws, and they don't necessarily coexist well. So Dr. Delaney was talking to us about challenges of integrating ELSI approaches in the collection of data, to knowledge of data, to practice of data, and sort of the challenges in all of those spaces. Dr. Meyer talked to us about the challenges of informed consent in the AB studies and sort of the patient bias and the participant bias and whether they want to engage in that kind of research, which sort of seems against their best interests in some cases. Dr. Sugarman talked to us about when sort of the most effective and efficient approach is obvious, but the regulatory structure is unclear governing that and how we can continue to navigate that minefield while OHRP at some point maybe kind of sort of decides to give us some more information. And Dr. Magnus on biospecimen exceptionalism from the participant perspective, which is definitely not currently reflected in the current common rule. Might again be in the future, but we talked about it for 6 years and we still didn't do anything. We know people care. And then Dr. Osler talking, I think you actually hit both themes, both the inequity stuff and also the sort of regulatory problems about this. I love this. The malevolent data exploitation sort of is this sort of bias concern, but in completely legal ways, because that's not how we're used to generating health data. And we're used to regulating health data in silos. And that's not the silo that we're used to getting health data from. And so we don't protect it at all. So those are sort of the two overarching themes that I saw from today emerge. But I'd be really interested in you guys' feedback because, again, this whole symposium is supposed to be building, right? So we're trying to learn things and not unlearn them for next year, so we keep repeating them. So I would be very interested, as would Jody, if you guys had more thoughts on sort of thematic things and ideas for future symposia and also speakers. I mean, this is an ongoing and building and living community. And we're very interested in your input, and that's why we brought you guys here. So thank you very much. I'm going to turn it back over to Jody.
You have a question? Okay. Sure.
Yeah, so thanks for that summary. Something you didn't say that I wouldn't be saying if you had said it goes to the fact that there's an S on the left side and no S on the right side after the word system. And I think that I heard over the course of several of the presentations a kind of implication, and I don't think it was intentional, but I think it played off of the singular on the right side, that there is one learning health system and it's kind of monolithic, and it's going to operate in a particular way. And I wonder if going forward and looking ahead to future ELSI-LHS meetings, whether we shouldn't be really amplifying that plural and thinking about many learning health systems operating on different levels of scale, that someday taking advantage of what I call fractal properties of learning systems might converge into one big system someday. But for the moment and for the foreseeable future, at least I think there are going to be many of them, and we should celebrate the different ways that they may evolve, and we're going to learn how to learn out of that diversity. So that's something I heard as a theme across the presentations, this tension perhaps between this singular learning health system concept and a pluralistic view that requires the S at the end of system.
I think I agree with you. But I'll think, yeah, no, it is. Well, I mean, it's an interesting point, but I think that is a tension, right? Because there are learning health systems, and we heard about many of them today, and there's you know, the sort of what are the fractal properties? What is sort of relatable at the individual level as well as the population level? But then there's a lot of variability between those two also. So I don't know that we'll ever resolve that tension. But maybe we'll change, maybe just next year will be the learning health systems in practice and call it a day. I don't know. Thank you. So from there, so just winding up, we were having some difficulties at the beginning of the symposium, so I didn't quite get to say thank you as well and as much as I'd like to. So I'm going to take that opportunity now. Our sponsors were from the School of Information, IHPI, the School of Dentistry, MISHAR, the Center for Bioethics and the Social Sciences and Medicine, the School of Public Health. The Brehm Center has been a sponsor for all 3 years, and of course the Department of Learning Health Sciences and the Dissonance Committee, which has supported us in getting the words out. Yeah, and there was a huge amount of work to get this all done. I'd like to recognize Paige Nong and Janelle, Elizabeth Cope, who's been a great colleague throughout this, Tava Platt, Daniel Thiel, I'll get to Georgie Ann Ziegler, Gracie Trinidad, Amina Raj, Trisha, Doreen, is what happens when I don't go in order, but Ray DeVries. But I think we owe all of them a huge round of applause. And thank you for being here. Oh, sorry, and HIMSS, who is our external sponsor. So we talked a little bit about this evaluation. It's really important, it's especially important now because we do need to sort of think about our own long-term sustainability. The first year, how many were here the first, have at least been to one of these symposia before today? How many have been to 2 or 3? Yeah, I mean, at this point, you've all been to one, and hopefully you'll at least all go to one more. And then hopefully next year we'll say the same thing. So the evaluation is the thing that allows us to do that. The overarching theme that I've seen every year is that the learning health system or learning health systems, however you want to frame it, is a model and an opportunity to create a system that's better than the one we have now. We're clearly building on top of so many things that have gone right and so many things that have gone wrong. And talking about the healthcare system or the health system or health as a learning opportunity is a time to think about what do we do better. Kim McGrail, who's here and was able to speak with us last year, talks a lot about the data and knowledge provide important insights, but are also very sensitive, which means we need to think carefully about how this is done, who should be involved in setting policy, and how we make sure those policies are followed. And I think that's a great summary of what we do once we know we're doing something, we want to do something better. we looked at these pictures earlier in the day. I think ELSI-LHS is one of these things that kind of help us put pieces together. It can reduce friction. It can highlight opportunities that we haven't seen before. It takes people and networks to do that. And looking ahead, we're hoping that this will be a sustainable learning community, that will be a community of practice, that will be the interdisciplinary and professional scholarly collaboration that people come to, that we can build and strengthen relationships. And finally, that we take these concepts of diversity, equity, and inclusion very seriously, and that we really live them in the practice and impact of learning health systems. And with that, we'll see you next year. Thank you.